Okay, so I was asked to give a talk about hybrid designs, and I've been, talking about this stuff for a good long time. We just put out a new paper in the very last month of last year, with some new insights and thoughts on these hybrid study notions, and I'm going to cover those also. Okay, so the goals for today are, give an overview of the basic hybrid study idea, drawing from our, first thoughts on it from the first paper in 2012, and then, give some updates on the thinking, some from a few years ago, but then a host of newly published thoughts on these study approaches, and hopefully time to take your questions. So some of this was already covered. I am a sociologist, so I started doing implementation-y work in our VA system in 1998, which is really our country's only single-payer, national system, which can be a nice place to try to do this kind of work. But I've also done a lot of funded work outside of that in lots of other settings, a lot of work focused on developing and testing strategies, but also doing a lot of work on design and methods. So I always like to say that I have always come at implementation science from the clinical kind of end of the world, hospital, clinic-based contexts, interventions for those locations, and some of the assumptions about these hybrid studies really came from that context, which I'll cover some more later, because it's kind of one of the deficits of the overall hybrid approach. In the past number of years, 7 or 8 years, I've also had a focus quite a bit on pharmacy practice interventions and on community pharmacies as a practice setting, which has been very exciting work. Okay, so for the next few slides, I'm going to cover some of the sort of the original thinking from the first hybrid paper, which we published in 2012. And so, thinking back to my early career in this field, trying to answer the question, okay, well, when do we or did we usually do implementation research? There very much was this sort of notion that, okay, well, in the research pipeline, if you will, folks are going to do a bunch of efficacy research. They're going to move on and do clinical effectiveness research, still often trials, but in more real world settings. And, then and only then, when we have a sense of, we have an effective intervention, now we're going to sort of try to figure out how to get people to actually do it in the real world. And when I first started in this field in the late 90s, again, in clinical settings, it kind of felt like a relay race, where you have a clinical researcher who's worked on this intervention, and they're kind of getting ready to hand it off to implementation and research folks to try to figure out, okay, well, how are we going to get these folks to actually do this effective intervention, one that we just showed works? How do we get this done in the real world? And so I would argue that, this is likely not the most time efficient way of trying to move these kinds of findings and these evidence-based practices into routine practice. And so we started to contemplate ways that we could possibly blend clinical effectiveness research, intervention effectiveness research with implementation research to possibly speed up the process. And so this intersection here is really kind of where we pitched these hybrid designs. Okay. Over the years, some folks have even, tried to pull this notion back to efficacy research. I'll mention that some later on. So, why even explore this, kind of hybrid approach? Well, like I said, the main goal is to try to go faster, right? Can we hurry up, please? We thought that, maybe if we're able to blend some of these effectiveness and implementation research questions in the same study, maybe we could save time. Maybe we don't have to wait for perfect or really good effectiveness data before moving into implementation research and trying to answer some of those questions. Maybe, for lack of a better term, we can backfill those intervention effectiveness data while we're focusing on testing implementation strategies. And more philosophically speaking, I mean, we do have a question out there which we probably should be trying to answer, which is, how do intervention outcomes relate to levels of adoption and fidelity of intervention and delivery? And if we don't have data from both sides, we won't really be able to answer that critical question. So hence, we hope that these hybrid study notions would help us, to move forward and to answer some of these questions. I always say that, people were doing this kind of blending well before me and my colleagues started to speak and, write about, hybrid designs. The first paper, we tried to bring some clarity, direction, on how to possibly do this kind of a blend or these kinds of blends. As I'll focus on more later, our first paper focused really on trial design. So there was randomization happening somewhere, and we kind of pitched the idea to trial designs. But a lot of people have used them in non-trial designs and used them really, really well. So we're trying to open that window, if you will. And at the moment, for me, this hybrid notion is, really about how to go about combining research questions from both sides. And I will cover more of this stuff later. So when I talk about implementation science in general, this might not be an audience that's, sort of needs this, but when we talk about hybrids, this kind of simple language is often helpful. So in this talk, you might hear me use the term the thing when I'm referring to the intervention, evidence-based practice, innovation that is the subject of implementation learning. In intervention effectiveness research, that's really focused on whether the thing works, whether the patients, the people who got the thing did better than those that didn't. And that is a category of outcome in all hybrid designs, in varying levels of emphasis. Implementation research, sort of as a field, to me, when you boil it down, really is really we are trying to figure out how best to help people and places to do the thing. Implementation strategies, which is kind of our field's term at the moment for our interventions, are really, in simple terms to me, sort of the stuff that we do to try to help these folks and places to do the thing. And our main implementation outcomes in this field, when you boil them down, to me, really are basically how much and how well that we get these folks to do the thing. And if de-uptake is a focus, then it's sort of how to get people to stop doing the thing. But these, same, terms apply. So I will use these simple terms often in this in my talk. Okay, so in the first paper and still now we talk about and sort of promote three different types of hybrid studies. Okay, hybrid type 1, which is essentially focused on testing of something, of some intervention, but we're gathering information on doing the thing, on possibly what might need to happen with the thing or the context to help implementation go better. Hybrid type 3s are kind of the opposite. These are focused on tests of doing the thing, tests of implementation strategies, but we're gathering information on the thing, on how well the thing is performing under the implementation conditions of our study. And then hybrid type 2 is the messy middle ground, really, where in varying ways folks are trying to test some intervention, test something, but also test doing the thing or a set or competing sets of implementation strategies all in the same study. Okay. I'm just going to cover real fast some of the basic specs of each of these hybrid types. Hybrid type 1, again, it's largely focused on exploring the effectiveness of some intervention. It's normally a standard effectiveness study. It might be a patient level randomized trial, plus an implementation focused process eval of some kind. And those analyses are usually focused on describing how implementation went during the trial itself, what worked, what didn't, trying to understand how the thing might need to be adapted going forward for better implementability or better fit in a certain context, and also trying to get a sense of what kinds of real world implementation strategies might be needed to support widespread adoption of this thing, should indeed it be shown to be effective. And so a hybrid type 1 study might be a good option when in your study context, effectiveness data of the thing might be limited. So it's probably too early to focus, a whole lot on implementation stuff. But the effectiveness study context, is a nice opportunity to explore some of these implementation issues, which are happening even during a randomized controlled trial, and to help to plan for future real world implementation strategies in a next stage, either of rollout or of research. Remember, all effectiveness studies use implementation strategies to help support delivery of the thing, but we usually just don't call them that at that stage. And we have a sense that in a lot of these clinical effectiveness studies, in clinical settings especially, that many of these strategies used are not going to be feasible for supporting widespread adoption. We're paying places to take part, paying interventionists oftentimes from study funds. We're paying for the care itself. Sometimes we have kinds of training and fidelity checks, which might not necessarily always work in the real world, but that's not the goal yet. But we can certainly learn from the strategies used and ask people, how many of these might, work in the real world, or how many of these might need to be adapted or to work, or what new strategies might actually be needed to help naive sites to do this thing in the real world. Here's a few examples from our slides. I'm happy to have you keep these slides and show folks. There's a lot of published work in all of these areas. Here's only just a few. Okay, I'll move on to hybrid type 2. So again, more the complicated sort of middle ground. There's some notion that we are testing some intervention and some strategy or strategies all at the same time, okay? In our first paper, we talked about two basic kinds of hybrid type 2s that we were either seeing or that we thought that we should see. And both are an intervention effectiveness study, but nested either in the study of a single implementation strategy where the places are not randomized to that. So it's sort of like a two-arm study of the thing, but a one-arm study of a strategy, which might be getting its first pilot test, okay? And then there's another kind of hybrid type 2, which is less common, but does happen, where there's sort of dual randomization. There could be a within site patient randomization or possibly clustered, but often a clustered randomization by site or provider of competing implementation strategies. Now that's a complex design. There are many out there or some out there, but these are the basic parameters. Frankly, there are some folks who also do a hybrid type 2 basically as a single arm study of both sides in kind of a program eval approach with a pre-post for both sides, and that's extremely common, and a lot of people do that too. So when is a hybrid type 2 possibly indicated? Well, you probably have some intervention effectiveness data on this kind of intervention, but perhaps not for the context of your interest or a population of your interest. And you probably already have some sense of like what the implementation determinants are, and you have developed some implementation strategies that you think might work in the real world, and you want to test all of these things at the same time in one study. A few key things to think about for hybrid type 2s. It's important to have, explicitly named and talked about clearly implementation strategies that are thought to be and hypothesized to be plausible in the real world. And this is a clear distinction from a hybrid type 1 study. In a hybrid type 2, there's always explicit measurement of adoption, fidelity, reach, these kind of more summative implementation outcomes that always happens in a hybrid type 2. And, just from being part of a whole lot of these, it's very helpful to try to be as clear as you can about the components of the thing versus components of the implementation strategy or strategies, even though that might not always be easy. Okay. Here's a few examples of strong hybrid type 2 studies. I'm happy to share more too later on. Hybrid type 3 is kind of the inverse of a hybrid type 1. It's largely focused on testing implementation strategies to do the thing most of the time, and effort on those studies go towards that. So the unit of analysis is normally at the place level or possibly provider level clinical outcomes or intervention outcomes are clearly secondary. Okay. So one might wonder, okay, well, why would we want to do a hybrid type 3 study and have those clinical outcomes to look at when we already kind of know that the thing works? Well, I mean, frankly, we sometimes move forward with implementation strategy focused studies when we actually don't have great effectiveness data. And there's a lot of reasons for that. But a hybrid type 3 can be helpful in that situation when a healthcare system has said, we're moving forward, we're rolling out this intervention, even though we don't have great data on it. So this could in fact be the only way or the best way to get data moving forward when there have been decisions made that we're not going to do a randomized trial of this thing anymore, or we can't, or we never could. Also, two, this is the kind of study where you can explore how intervention effectiveness varies by the level and or quality of implementation, which, you know, is a critical question that I think our field probably needs to do better at. And there are certainly effort and cost implications around that question. And if you do cost analyses in a hybrid type 3, that's very helpful to help people to know, like, what's the cost-effective dose of implementation that we need to try to make sure that we get the clinical outcomes that we're after. Okay. For hybrid type 3s, there's a lot of considerations here about, you know, if it's a site level study, well, how many of those places do you have, and as a result of that, you might then be sort of led towards a certain kind of research design, whether that be a parallel cluster randomized trial or a step wedge, a rollout design, a smart design. I mean, it just kind of depends. I list a couple of papers here which are helpful with choosing research designs for hybrid studies. And so here's a few, nice hybrid type 3 studies. There's a lot of hybrid studies published out there now. We're doing a scoping review with about 500 studies. So it's been a slog that's been happening for a very long time. But the good news for you is you can go out and search for hybrid studies that might be like what you're thinking about. So there's a lot of cool models out there for you to follow. In our 2019 update paper, we made the argument that, maybe hybrid type 1, should be less of a special case and maybe a more routine approach to effectiveness studies. And in my country, this, kind of seems to be happening, if you will. There's a lot of hybrid type 1 effectiveness trials being funded, and sometimes, folks who turn one in that wasn't one, funders are asking people to add that, to it. And we've also seen in our scoping review that, folks are trying to apply this notion to earlier efficacy work, and also sort of pilot studies too. Perhaps to hybrid type 3 could maybe is less of a special case. I was at a hybrid focused session at a DNI conference, and one of the attendees stood up and said, okay, well, I mean, when wouldn't we want to also have patient level intervention outcomes? And I think that's, I think that's a good question. I actually mentioned a couple of cases where I don't think that you would. I don't think everything needs to be a hybrid study. But, I do think it's, good for us as a field to essentially prove how much fidelity is important to outcomes and under what circumstances. And you can only really do that if you have these kinds of data. And for hybrid type 2s, this is more of a risky study. You are testing implementation strategies, that might be relatively new in support of a clinical trial. And if those strategies underperform, you can put your trial at risk. So for these kinds of hybrid studies, we highly recommend, that you fully justify why you're doing this and to build in some fail safes to make sure that if that you will learn that your implementation strategies might not be doing well with fidelity or adoption, and you're going to have to make changes to those during the study in order to try to make sure that you don't wreck your effectiveness study. So, the hybrid type 2s, perhaps are not for the meek, but they are certainly possible. And a whole lot of people do them. As I noted, we had a working group of these folks here, and we wrote a paper last year, which we published in December, where we tried to reflect on the first 10 years of people trying to do this hybrid stuff, with a critical eye. And we talked about in our paper, we framed it as like answers to 5 questions. And these are questions which we often got in our consultations on study designs, or in our many workshops, which we have done over the past 6 or 7 years on hybrid studies. And so a big question that we commonly got was, well, are hybrid designs really designs? And that's what we called them in the first paper. And we thought a lot about it, and it basically depends on your definition of design. But it was certainly clear that our first focus was on trial designs, and the field has clearly told us that that was too limiting, because a lot of people have innovated in this area, and they have applied these hybrid concepts and the notion to lots of different kinds of designs: quasi-experimental, program eval, UI type designs, a lot of pre and post, even post only designs. So the core notion is trying to answer intervention effectiveness and implementation questions in the same study. And you certainly do not have to have it be a trial in order to do that basic approach. So we even recommended in our new paper to maybe drop the hybrid trial design language and to talk about them more as hybrid studies. And that's what I am trying to do myself. But having talked about this probably more than anybody else, over the last 11 years, it's probably hardest for me to drop the T word, but I'm doing my best. Okay, the next question was really the main one that we have gotten a whole lot we've done a lot of workshops, and this work in the paper came from that. So the next big question was, well, which type of hybrid should I do? And so what we tried to do was to come up with a series of 4 questions that you can go through as a team to help you to make a good choice about what seems to be the best hybrid for you, if you even need to do a hybrid, based upon some information which these questions solicit. And I'm not going to go over every single one of the under bullets here, but basically the questions are focused on what's the nature of the effectiveness data of your intervention of interest. And depending upon how strong it is, that has something to do with which kind of hybrid might make the most sense. The next question is related. How much do you expect the intervention will need to be adapted for where you want to study it or to use it? Okay. And so if you don't expect that it needs to be adapted or changed much, and you have some pretty good data on it from question 1, you're likely leaning more towards a hybrid type 2 or a hybrid type 3. If you expect that it's going to need to be adapted a lot for where you want to test it or with whom, then you're probably best leaning more towards a hybrid 1 or a hybrid 2. Next, how much do you already know about implementation determinants for the intervention in your context or population of interest? If you don't know much and you also need effectiveness data, you don't have a whole lot there, that's a really a pretty clear case for a hybrid type 1. If you already have strong effectiveness data, and you know enough already about implementation context and some of the barriers to doing the thing, you might be ready to do a hybrid type 2 or 3 study, which has a co-focus or main focus in a type 3 on implementation strategy testing. The last question: how ready are you to evaluate real world implementation strategies or packages? Okay. So we recommend, as many people do in our field, that implementation and strategies that you might want to test should likely be matched to and tailored around implementation determinant work and sort of known barriers, facilitators to doing the thing in this setting. And that's really the third question. So if you answered 3 that you have a lot of knowledge, you might have even gone further to develop and possibly pilot test, or develop but you haven't yet pilot tested, some of these real world strategies which you think might actually work. And so if you are ready to do that, you're clearly more in a hybrid type 2 or hybrid type 3 situation. Okay. And remember, you don't need to do a hybrid study. You could find yourself in a situation where it's basically too early for a hybrid. For example, if some intervention hasn't really been established as being safe yet, you might not want to look at implementability stuff until you've crossed that bar. you should absolutely question how much you need to look at intervention effectiveness. And there are a number of cases where that just isn't going to make any sense. For example, if you're studying strategies to help people, to help pharmacists, for example, do more vaccinations, we're not going to test the effectiveness of the vaccines. We don't need to. So in that study, we would only focus on implementation strategies. And so it wouldn't be a hybrid 3, it would just be an implementation trial. Or, certainly, if you're focused on doing early work on the context and trying to understand determinants of uptake, you're not really in sort of hybrid land yet. Okay, so please be thoughtful about this. You don't always need to use these things. And it's really critical when you say that you are going to do a hybrid to justify it to your funders and partners. We get this a lot. So which research design should I use within a certain hybrid type? It largely depends on what you're trying to answer, okay? And I would not argue that like certain research designs are like exclusively tied to a certain type, but I think that there are some generalities. For example, the type 1 studies look at testing interventions normally at a person or patient level. So a lot of these studies are individual level randomized trials. In type 3, the focus is normally on studying and often comparing implementation strategies. So a lot of these studies use clustered designs or a place level focus, whether you're randomizing or not to compare 2 or more strategies, or if you're not, you're still likely going to have a clustered design. Hybrid type 2s are a blend of these other 2, and sometimes there's a relative emphasis on the thing or on strategies, and that emphasis normally tends to drive the design choice. And I also want to mention too that a lot of people are using the hybrid approach and concepts in observational studies, in non-randomized studies, stuff with pre-post designs, interrupted time series, for pilots. Obviously, you have a small number of sites and people. There's a new paper out just a month or so ago, which talked about applying the hybrid approach to observational studies. And we also have a paper that's under review now, which is trying to apply the hybrid approach to policy implementation studies. I am going to stop in just a minute. So also, I always like to say that your research design in our field is often, partially to fully dictated by how comfortable your partners are with being part of a study and what they're comfortable doing or not doing. Hence, a lot of stepped wedge designs in our field, because those often seem to be more they seem to sort of make community partners happier. Okay, here's some of the challenges for the typology. It never really worked well with health promotion or public health type interventions, where they often don't do sort of hybrid 1 efficacy stuff, and they never really try to test any intervention in this realm without at least some real world implementation strategies, which they've developed. So for this kind of work, they kind of often start with hybrid 2 and hybrid 1s just kind of don't make sense to them. I also just want to mention that not everyone agrees on what the thing is versus what the strategy is. We have some colleagues who are about to turn in a paper, which hopefully will give a lot more, guidance here, but it's plausible that you could have the same study and it could be a hybrid 1 or a hybrid 3, depending upon how you classify what the thing is, okay? And then last, we had some thoughts about cost, which I will not share because I didn't write that part and I don't fully understand it anyway. I just want to say, we hope that this new paper, has helped people, to better manage thinking about and possibly doing hybrids. I want to thank you for your attention, and I'm happy to take questions. And I'll probably end the slideshow so I can see more of you, if that's okay.
That'd be great.
Good, Janet? Okay.
Perfect. Thank you, Dr. Curran. That was a fabulous whirlwind tour.
It's a whirlwind tour. Yes.
So
41 minutes. So yes.
While we are waiting for folks to pop some questions in the chat, I will take advantage, although there is something there that says really helpful. Can we have reference for your new paper? There's a ask for a reference for your new paper. I will take advantage of the opportunity to ask you a question. When you are consulting with people on their potential hybrid studies, what are some of the major issues that come up when trying to decide on which type?
Yeah, so the first question that I ask, and that was how we came to even write the paper on the thing stuff, was, okay, what's the thing that you're trying to get people to do or stop doing? And we try to get clear on that. And then it turns into, okay, well, how much do we know about the thing and how well it works where you want to apply it, right? And then we kind of move there to, okay, well, how much do you know about how easy or hard it might be to do, something in a new setting? How much work have you already done on those determinants? And just trying to figure out where people are. Are they ready to develop and pilot test a set of strategies, but that's all that they want to do? They don't have evidence on a set, and they're ready to compare strategies and have that be the focus. Most of the challenges come when somebody has the sense that I know I need to do effectiveness focused stuff still. And I probably want to do a patient level randomized trial of some kind, but I don't know if it's if I should do a hybrid 1 or if I should do a hybrid 2 where I might try some strategies at the same time. And that's the most common area where folks really need to do a lot of thinking, and I try to help them over it. Oftentimes folks go, hey, I've pilot tested strategies blank. I'm ready to do a comparative study of those. Effectiveness data is, pretty good, and we're not needing to mess with the intervention much. And it's like, you're hybrid type 3, you are good to go, right? It's the 1 versus 2 that's often the key place where people go, help. And I try to help, and other people too. And this paper, hopefully.
Thank you. We have a question in the chat, and we have Rachel, you have your hand up. I'm just going to take the one in the chat first because it popped in there first, and I'll come right to you, Rachel. So this is a question that from Ken, who said, after 10 years and hundreds of hybrid trials and funders asking for this type of design, are top tier journals ready to accept hybrid designs as a proven and often optimal study design. Is there anything investigators can do to help ensure editors and reviewers understand the rationale and importance of hybrid designs, particularly the nuances of the different subtypes?
A great question. You know, a lot of hybrid type 3s go to implementation science and those kinds of journals which like explicitly focus on those. And for that audience, when you use these hybrid terms, people kind of are more likely to get it, right? I think it becomes more of a challenge maybe in sort of the hybrid 1 and hybrid 2 worlds, where some of the journals might be more comfortable with, here's my clinical trial. And you're trying to get them to understand like, oh, we also did a process eval on implementability, and I want to talk about those data too. Or in a hybrid type 2, it's like, yeah, and at the same time, I tested these strategies. So those, I think, face a larger challenge. And there are some ways that people have, tried to get around this, like they'll publish the non-hybrid data, only the clinical effectiveness data in the big journal that they would want to shoot for anyway. And then the hybrid 3 implementability focused stuff is in a smaller paper, which goes to somewhere else and it's separate, right? And even for some hybrid type 2s, folks have like, here's my effectiveness paper, and I only talk a little bit about the strategy stuff, and that'll go to, JAMA or Lancet or the big, journals in clinical areas or content areas. And then they peel out the strategy stuff and they send that to more IS friendly journals. So, I mean, I think people are seeing them more. You have to justify them well to get funded in the first place. So hopefully you can use some of that language which you've already used in your papers to try to get the journals to be, ready for it. I think, you can cite my new paper, which, shows that, there's 500 plus published hybrid studies at least that we could find. So this is popular. Lots of people are using these. And so I think you can make that case also.
Okay, thank you. Questions coming in fast and furious now.
Okay.
So, Katie, I missed you, and I'll come right to you after Rachel asks her question. I'll go to Katie, then go to Dawn. No, you're
Still
on
can't
mute.
hear you. Sorry.
What about now?
Yes.
Okay.
Great. Good morning. Thank you for the tour. Curious how you've approached funding this type of work. I think, I'm in the US and NIH is, I think, a little bit more open now to funding the type 2 studies if, you have the luxury of planning it outright and stating that you're going to measure.
It's the hardest one.
It's the hardest one, but I think there is some, at least warmth
Yes.
developing in this space.
Yes.
I'm curious if you have tried submitting, because sometimes things already happen and we might want to test the implementation of it. Have you written grants sort of, around that type 3 type of grant? And then more generally speaking, Are there funders that you found to be more receptive to these types of grants?
So yes, and apologies for being kind of US focused. NIH has multiple subgroups based upon like cancer or substance use or heart, lung, and blood, whatever. And each have their own level of interest and comfortability with implementation science. And so like for NCI, for NHLBI, For some others, they're extremely comfortable with this stuff and they have been for years. Hybrid 1, hybrid 2, hybrid 3, they're on board, they get it. Project officers get it. And, it's less of an issue. At some others, it can be sketchy. NIMH, the mental health one, they're comfortable with 1s and they insist upon 3s if you're comparing strategies because they always want outcomes. So they have on their website, it says, don't turn in an implementation trial that doesn't collect clinical outcomes. But for hybrid type 2s, they don't quite know where to put them. And sometimes they can get squirrely. With the mentee, we just turned in a strong hybrid type 2. We made all the arguments and we underlined, bolded text to try to make our point, and we're hopeful, but we shall see. I mean, we've had some project officers try to talk us out of turning in hybrid 2s because of their concern at their funding agency that people are much more comfortable with a hybrid type 1. So please explore with your funders how comfortable they might be or not with hybrids in general and which types, because there are strong opinions out there.
Great, thank you. Katie White, do you want to unmute and ask your question yourself rather than me reading it for you?
Sure, thanks very much. Hi, thank you for your presentation today. I really appreciated the comment at the end about how many of our designs are only as strong as our research partners are comfortable with.
Yeah.
That's something I've lived as well. And I was just curious if you could expand more on how you have negotiated those conversations and the scientific real world trade-offs in your work.
Sure. I mean, we oftentimes, work with people from the kinds of places in our pilot work. And we'll just ask a lot of people either through qualitative stuff or focus groups or something and sort of just say, hey, we have a few ways to do this, so folks might be comfortable with this notion that, well, we want to test a standard implementation approach versus that plus facilitation with a bunch of coaching and hand holding. And then we say, well, there's a number of varying ways that we could do this. There's this way where half the pharmacies get 1, half get this, and that's it. Or one where everybody starts with 1 and then everybody crosses over to 2, a wedge design. Another where everybody starts with this and then we see how well people do. And for the people who still aren't doing great yet, we then randomize people to either a little more time with strategy A, or we switch to B. And then they can kind of vote, if you will, or just tell us what they think they are most comfortable with. And or if you're able to fund kind of a non-trial crossover at the end, you also can possibly get folks to be comfortable with, a randomization where some get and some don't. But you give it at the end, either for people that say, hey, I want facilitation, please, right? And if you can afford it, and if it makes sense, that's an option too, which might not necessarily be part of the powered study, but it might just be a nice partnering thing to do. Right.
Great, thank you.
Sure.
Dawn.
Thank you very much. I'm Dawn Stacy, a professor in the School of Nursing at the University of Ottawa.
Hi.
And I found this extremely helpful. I'm glad I attended. So I do a systematic reviews of KT interventions. And so I just wanted to bring this up. So where I get confusion, well, first of all, I didn't understand the 3 hybrids, so this is helpful. But we're doing a systematic review on does the thing work? But we can actually gather data then from some of the hybrids, because when the hybrids report the effectiveness, does the thing work, then it makes sense that we would pull that data and include it in a systematic review. Yes. Whereas sometimes I get more confused when it's really more of an implementation study.
Yeah.
And then it more of the hybrid threes where I'm like, I'm not
Yeah.
sure if it's really actually pulling effectiveness data that's relevant to what I need.
And it probably isn't. So like a hybrid type 1, it probably is. Most of the hybrid type 2s, it probably is too, because there was sort of a patient level comparison normally randomized of the thing versus some other thing. In a hybrid type 3, you get effectiveness data on a thing, but it's only one thing. And the comparison is how well the thing did under implementation strategy A versus B. So like in my current study, we will have data on how much more or not effective the intervention is when the pharmacists get coaching on how to do the thing for 2 months, which we assume will make fidelity better, which we assume will lead to better outcomes. We're studying all of that, but we'll only be able to say the effectiveness of the thing was better under facilitation than standard implementation, which was only training in the thing and a few cheat sheets and tools and other things. So it's probably not what you're after, but for other people, that's really interesting data, right? Because if you're pondering like the cost effectiveness of implementation supports to help people do something in the real world, it's helpful to know how much implementation support that they might need to do it well to get the kinds of effectiveness outcomes that we want, and how much that might cost.
Right. Thank you.
Sure.